Hello, and thank you for downloading another episode of Your Life Simplified. As you know, if you've been listening to this show is all about improving and simplifying people's lives through education. So we try and educate you by bringing on experts in a variety of different topics. On this episode, we're going to discuss the opioid epidemic because of the impact it's having on families across the country. And we know it's a really complex issue because it's medicine. It's a necessary pain reliever. But having said that, the opioid crisis is costing the U.S. economy over $500 billion a year every year. In the United States, over 2 million people are addicted to it, and on average, 115 people die every day from overdose. So it doesn't matter if you're someone from the inner city or from the wealthy suburbs, a teenager or a baby boomer, it does not discriminate. It's an issue that continues to grow, and the more educated that we can all become on the topic, the better we can help navigate these issues with friends and loved ones or someone that might be dealing with this. So today, I'm excited to have an expert with us on the subject. His name is Dr. Chris Jensen. Chris, welcome to the show.
Thank you so much for having me.
So Chris, just a little bit about your background. You're an expert in this field. You spent 13 years as an emergency room doctor. You spent time with the CDC, and now you're in education, right?
Yeah, it's kind of a funny path, but those are the areas that I frequented in life. And it's nice. It's a nice perspective to grab when you're looking at the opioid crisis because it is inherently a science-driven topic, but it is making a profound impact on society. And it's one that we really all need to look at the facts and gather what's going on. And there's no way to tackle this until you really get your mind around it.
So Chris, I shared a couple of quick stats with us, but can you give us some background on what this looks like?
Sure. First of all, a lot of people don't realize the extent of this epidemic, and the media has jumped on board recently, but this has been a problem that's been brewing for some time. It is actually as bad as it's portrayed to be. It is a problem, as you mentioned, Brian, that involves 50 states, every county in America, local municipalities everywhere. As you said, it doesn't discriminate and everyone's involved. There's literally no spot in the United States that has immunity from opioids. And of course, it is lethal. Approximately 115 to 130 Americans a day are succumb to unintentional opioid overdose. And those are the reportable cases. We have no idea what goes out there that doesn't make it to the hospital or to the law enforcement agency. And I honestly can't imagine the numbers of users each day that come close to a terminal event. And so to really wrap your mind around this, you got to go back to when it started. And so we're talking around 1999. And at that time, there was a big emphasis in healthcare to do a better job addressing pain in patients. And there was a lot of valid reasons for that. The perception was that healthcare providers were not adequately treating it. And so at that point in time, the Joint Commission on Accreditation of Healthcare Organizations, also known as JCAHO, put forward some really good directives. And those directives were really to take care of the patient, and they were looking to improve the quality of care when it came to pain management. Specifically, JCAHO had three, if you really simplify it, had three guidelines they wanted providers to consider. One, they wanted a reliable, consistent method to assess pain in patients, whether that was outpatient or inpatient. Second, the hospital needed to reassess and respond to the patient's pain. So it wasn't a one-time deal. You know, you're in the hospital for a little while, you're in the ER for 5 hours. How are we doing with your pain management? Where is this going? What's our trajectory? And then finally, the hospital either treats the patient's pain effectively or refers the patient for a professional help, such as an anesthesiologist or pain specialist, as an outpatient basis. And that was the intent of those guidelines. And they were released around 2001. However, those guidelines probably didn't fall into the practice that JCAHO and Medicare and other regulatory agencies were hoping for, because here's the reality of how they sometimes got applied. A lot of people would claim in healthcare that really pain became a fifth vital sign, that there now became too much focus on it. People might also say that they thought that pain assessments had to apply to every patient that walked in the door. A lot of clinical practitioners also felt that you had to treat the pain aggressively till their perspective score of 0 through 10 was a 0. And the fear was that if pain wasn't treated properly, that a hospital could lose accreditation or that there could be financial implications. Now, I'm not saying that every healthcare provider in America felt that way, but that's kind of a gestalt that a lot of practitioners felt was being recommended. And so instead of finger pointing and blaming an individual or an organization, all I can tell you is around 1999-2000, this desire to treat pain more aggressively started. And we think, we don't know for sure, but we think that's why we started seeing an increase in the amount of pain prescriptions, specifically opioids at that point in time. And we'll get into it later, but we saw a dramatic increase in the number of opioid prescriptions right around 2000, and that has continued to rise persistently through 2017. And then 2018-19 data is still really being finalized. But that may have been the start of it all. And so now you find yourself in the United States with a great deal of opioid prescriptions out there in the community, and suddenly access to opioids became quite prevalent.
So Chris, those stats are really interesting. The one that sticks out to me is not only the emphasis that people put on pain management, but that whole threshold of how do you measure pain? And the doctors generally say it's 1 through 10, 10 being the worst. How do you feel? Well, I don't know. It's all relative, right?
Yeah, it is. It's hard to quantify something scientifically that's your own personal perspective and impression. Exactly. And I think the intent behind the rules was to make sure we're taking good care of patients. But I think possibly in medicine, we lost the forest for the trees. And it became obsessed about a number and driving pain scores down to 0 aggressively. And I'm not trying to suggest that every practitioner did this, but there became a little bit of an obsession of pain management.
Well, you take the patient out of pain, they're going to be a happier patient, right? And then if it was the worst case scenario, all of a sudden you're not giving them enough medication, they're in a whole lot of pain, and then you potentially have some sort of, liability, or we live in a litigious society and things of that nature, right?
Absolutely, yeah. And, not only is it ethically and humane the right thing to do to treat someone's pain, but, I'm not going to lie, it affects the business perspective of the hospital. Yeah. These patients are wonderful people that need help, but from an administrative point of view or from a hospital point of view, they're also clients, and you want them to be happy.
That's a great point.
So, Brian, if you look at the gestalt from 1999 to 2016, drug overdoses resulted in 632,000 reportable deaths from that time period. And over 351,000 of those were attributed to opioids.
Wow.
And that was a massive spike that we'd never seen before.
What does the crisis look like in America? I mean, are there certain common threads or patterns that you see where folks struggle?
That's the thing about it. It's odd. It's very different. In many ways, the surge in opioid use does not match the typical patterns of drug abuse that law enforcement and healthcare are used to seeing. So typically, if you think about drugs of abuse, you might think of it being potentially an area of poverty, or perhaps an inner city location or something along those lines. Often it involves the young. And if you look at the breakdown of opioid deaths, CDC published a really good morbidity and mortality weekly report in 2016. And I'm just going to jump to the facts. But what they found is the most prevalent user that has access to opioids is typically between the age of 30 and 55. They're often Caucasian, they're usually male, and they're most likely from South or Western states. And this is not what we're used to seeing. And there are a lot of theories as to why that is. And although we'll never definitively know, one of the leading theories is these are the people that have access to healthcare. These are the people that can gain prescriptions. So not everyone walks into the doctor to become an opioid addict. That's not how it happens. But they're being prescribed these meds. And what we find is that when they get access to them, they accidentally go down this road and become dependent upon opioids.
So let me ask you a question. I mean, as a doctor, you've given a prescription out and, hey, within 30 days, you should be off of these. And maybe I had some sort of procedure. And after those 30 days, I call the doctor's office and I say, hey, I'm still in a lot of pain here. I need more meds. I mean, do they just write the script just from that conversation, or is there further analysis needs to be done?
No, there's a lot more stricter guidelines in place, and I'm glad you brought that up. There are things that are being done at this point in time to try and change how we approach pain management. And certainly over-the-phone prescriptions, things like that, lacking reevaluation, are not a good way to go. And I think healthcare providers realize that now. Rather, we're trying to set up more of a dynamic, continuous relationship with the patient as they're recovering, and making them check in with office visits and seeing them in person, and setting realistic goals. And specifically, instead of talking in vague generalities, really the Center for Disease Control and other regulatory agencies are encouraging physicians and those that deal with opioids to do 3 things. First of all, be more judicious and thoughtful about prescribing. Opioids should never be first-line therapy for pain management. You also have to sit down and have a nice conversation with the patient and say, look, I'm probably not going to make you pain-free, but here's my realistic goals. And we're going to use these medicines in conjunction with non-narcotic medicines that are also effective in certain ways, and we'll kind of create a treatment plan. And then being smart about it, using immediate release opioids that are not as chronic or long-acting. And of course, using the lowest effective dose. And I'm not going to lie, that's a lot more work and effort on the healthcare provider, but it's the right thing for the patient to have those conversations. And then the second is, preventing opioid disorder. Pharmaceutical companies have jumped in and they're trying to alter their formularies so that physicians can't even write some of these higher dose, longer acting opioids that put people more at risk. That's a good thing. That's called formulary management. we're educating providers. We find that mostly it's general practitioners that are writing the greatest number of scripts, innocently enough. And they're not as trained in pain management per se as an anesthesiologist or perhaps an ER doctor or surgeon that's a little more versed in them. However, with good education, they're just as educated and they're doing a much better job in recent years of monitoring those scripts. And then, something that you and I have talked about, not all states do a good job regulating narcotic prescriptions. Not all states, believe it or not, have in play drug prescription monitoring programs.
Which just blows me away.
It does me as well, and you can imagine that if a prescription were issued, let's say in a situation with a city that's on a border between two states, I'll pick Kansas City, which I'm familiar with. Missouri doesn't really have the same monitoring programs that Kansas does. And it's conceivably possible if someone wanted to be deliberately fraudulent to fill that script in both states with the left hand not knowing what the right is doing.
And do you know why that is? Why would a state like Missouri not want that? Is there a cost associated with that? Is there just administrative red tape and things of that nature? And why would they not want that in place for their citizens of that state?
Yeah, the details of the Missouri government, I'm certainly not an expert in. So I'm going to dodge that question. I am not sure. But what I can tell you is there's a lot of federal pressure for not only for states to get monitoring programs in place, but to also link and talk with each other. And there's making some good headway in this area.
Makes a lot of sense.
Yeah, absolutely.
So, Chris, it's really interesting to hear what the manufacturer of the drug companies are doing, coming out with some of the, maybe it's a less lethal form of pain management. In your experience, and we're talking obviously a lot about Western medicine here, have you seen any non-Western medicine be used or leveraged in, as part of the healing process in different types of procedures? Or are we just not there yet?
My experience with that is mainly limited to patient encounter and a little bit anecdotal. But yeah, there are patients, for a fine example is patients that are unfortunately dealing with terminal cancer and have a lot of pain needs. And some of their therapy is traditional pill-based medicine or Western medicine. And others pursue acupuncture and a variety of alternative choices. And it really comes down to each their own. As you mentioned earlier in the podcast, pain is a subjective I don't want to say opinion because it's definitely there, but a subjective assessment.
Sure.
And so these non-traditional therapies for a lot of patients are very effective and certainly can be pursued. And if they work, that's great. It reduces the need for other pain management solutions and would inherently reduce the amount of opioids someone needs access to.
Yeah, absolutely. And obviously less addictive, cause less pain, things of that nature, going back to what the doctor's Hippocratic Oath, right?
Absolutely. Do no harm.
Do no harm. So it's interesting to hear that, we're beginning to incorporate both Western medicine and non-Western medicine. But I think we all realize in this country, the way a lot of us deal with pain is through pills and those types of things. And so when I think about the crisis that we're talking about, there's probably a couple of different ways in which people get hooked and do whatever they need to do to make sure that they're receiving this type of pain medication. And so generally they get it after a procedure. But once they do get hooked and they can't get any more from their doctor, is that when they go to the black market and start buying it in the street? What does that look like? What's maybe the split between those that get their medicine from the doctor versus those that are getting them on the street?
Sure. You ask a very smart question. And it's interesting because there's a very distinct timeline that has brought the opioid crisis into 3 unique phases. So I mentioned the fact that there was a rise in prescriptions starting in 1999. And you know what? That rise was so profound between 1999 and 2016, opioid prescriptions quadrupled. Wow. And so what I want to get out there is that there are a lot of scripts. Now, what we saw around 2010 was a very sad statistic. There was a dramatic rise in heroin. And heroin became a significant overdose death again. And we believe that what was going on is between 99 and 2010, we started cracking down on healthcare providers and becoming very stringent and restrictive in many ways and doing some good education, limiting the number of prescriptions. So now you can imagine a scenario where, let's say I go for an innocent dental procedure and appropriately from my dentist get prescribed some pain meds. And I take them the way that I'm supposed to, but now I'm finding that I really feel like I need these opioids and I ask for refills. And maybe when I'm truthful with myself, my tooth pain's pretty much resolved, but the dentist is trying to do the right thing and providing me with a humane treatment plan. And then the dentist tells me, you know what, Chris, you really should be over this pain by now. I don't feel comfortable writing you for another script. But now I'm addicted. Yeah. And so what am I going to do? And I could try and pursue a prescription from another means. My brain is now chemically reliant on this drug. It's not a sign of weakness. It's a physiologic dependence.
And that's what I think a lot of people get confused about, right? This isn't just something that I really want. At this point, it's something I really need, right?
Absolutely. Yeah. Opioids, you bring up an excellent point, are a great pain management solution because they block a lot of the pain fibers coming up through your spinal cord to your brain. And that means that your brain doesn't encompass or feel the same significant amount of pain, which is good. But the downside is that's not the only place they bind. They also bind to areas of the brain that trigger dopamine release. And dopamine is a neurotransmitter we've studied a lot, and it happens to be associated with pleasure.
Yeah. And
so these chemicals release this pleasurable response. And presumably, when you take the pill, you get that dopamine rush and you get that pleasurable response. And frankly, anyone would want to continue feeling that way. And when the drug wears off, you lose the response. There's also some changes within the brain itself where you literally become more dependent at the receptors in those nerve cells. You become more dependent on a higher drug dose. And so not only do we see people sadly needing this medicine physiologically to continue, but they need even higher amounts. And that's where things get very dangerous.
You bet.
Yeah. So the reality is, if I'm stuck in that situation where I'm now physiologically addicted and I can no longer gain legitimate prescriptions, I'm going to go get it from other options. And that likely would be from a drug dealer. And it starts very innocently. Maybe you know a friend that has access to XYZ and you try to acquire it. And now all of a sudden you've got that phone number in your speed dial.
Yeah.
And so that was the second rise. We saw a rise in heroin around 2010. It gets a little worse because heroin itself is fairly addictive. It's very similar to opioids, but there's a more powerful addiction out there, and it's semi-synthetic opioids, and it's known as fentanyl. And what we saw was drug distributors and cartels got wise, and they decided to mix in fentanyl with some of the heroin they're distributing, so that although the high or rush really didn't change, but the physiologic dependence increased significantly more.
Wow.
And so what they did really was kind of prey on someone's current addiction and make it more profound.
Yeah.
And so we saw fentanyl rise shortly after 2010. And you can imagine how this spirals out of control. You know, I start just taking some pills for an innocent procedure. I can't get off the pills. I'm buying heroin. Now they've tampered with my heroin. My addiction's really tremendous at this point because you're not dealing with an honest group of people, and things just go out of control. And that becomes all I can think about in my day now.
Yeah, it's amazing. It just takes control of your entire life. And I think from the outside looking in, that's why I said it's sort of need versus want. From the outside looking in, I don't think a lot of us can understand exactly what that looks like and how fast that can take place.
Yeah.
Thanks again for downloading this episode of Your Life Simplified, which is produced by Mariner Wealth Advisors. And at Mariner Wealth Advisors, we're here to serve as your advocate. We help people chart a course to reach their personal and financial goals so that they can have greater peace of mind that may lead to a more fulfilling life. We do this by always putting our clients first. Because as fiduciaries, we're required to provide guidance that's in the best interest of clients, not in the best interest of a company or shareholders or anyone else. So as you listen to this podcast and have questions about maybe your own financial situation, or would simply like a second opinion, or even you have an idea for a future podcast, please go ahead and email us at podcast@marinerwealthadvisors.com. If you found the information on this podcast valuable, please go ahead and share it with a friend or family member that you think might benefit from this information. And please don't forget to subscribe to this podcast so you don't miss an episode. Thanks for listening, and now back to the episode. So in the spirit of somebody, actually getting hooked, many of us are taking these medications when we need to appropriately. But if I was to go in for a procedure today because something happens, now, of course, I don't want to be one of those numbers. So how at risk am I? I mean, what's going through the back of my head is I'm going to do everything I can not to take these. And that's probably not the right idea. But how fast can somebody get hooked on this?
That is a point that shocked a lot of prescribers. The CDC came out with some good data in 2016 again. And what they showed, they focused on, number of prescriptions and chances of getting hooked, and then just number of days you're taking the script. So it's not surprising to someone that if I get multiple refills for opioids and I take them over an extended period of time, that my chance of getting dependent on opioids is quite high. What I think shocked a lot of medical providers was this one. If I write what I previously thought was a very simplistic, straightforward, and small prescription of opioids for 5 days, I'm actually giving that patient about a 10 to 12% probability of being dependent on opioids at 1 year.
That seems really high.
It does to me, yeah. And I think it was a shocker for us. And that forced a lot of healthcare providers to really take a step back and think and say, okay, opioids aren't necessarily a bad thing, but I want to be a lot more cautious and conservative about how I prescribe them. And infusing other pain medicine that are non-narcotic based right out of the gate and using opioid for breakthrough pain in a shorter duration is really the way to go. Because, Brian, like if I don't know, maybe you had a bad fracture and I write you because you're traveling across the United States, you're not going to be back to your primary care doctor, and I write you for 10 days, and maybe that turns into 15 days. And now you've got about a 32% chance of being dependent at the end of 1 year. So we were very shocked and surprised when the CDC published this to see that there is quite a significant dependence with a rather short duration. And I think the figure that humbled me the most was that at 5 days, I'm really actually giving someone like about a 10% chance that they might be dependent at the end of 1 year. And that really changed my practice style.
Yeah, I'm sure it would, as it would many, I would think.
Yeah, and to your point, I'm not sure a lot of patients are aware of that, and kind of changes the spirit of the game. I think patients and doctors are more willing to work together. Like, hey, I may not be able to make you pain-free, but I want to make this tolerable for you, and we're going to try some non-opioid meds, and you can have a small dose of these for breakthroughs if you need, but here's why I'm restricting them for you.
Then maybe just inserting some sort of pain management, person into the mix. Is there someone that's in between sort of the doctor and the patient as it relates to those sorts of things?
So the answer to that is it depends. Some hospitals are more streamlined and have follow-up procedures that are a little different, interacting with the patient. But the general school of thought is no matter what your situation is medically, whether you're practicing in an urban setting or a rural setting with maybe less funding and bandwidth, you're looking to make contact with the patient more frequently. Instead of it being a one and done process where a procedure occurs, I hand you a prescription and then say, hey, Brian, good luck.
Yeah.
It needs to be more constant interaction, not just about refills, but rather, how's your pain doing? And if I call you up on day 2 and you're like, it's actually pretty tolerable, great, then let's get you off opioids today.
Yeah, I think back about, I've had both my knees scoped and I've had my shoulder done and, I've been given the pain medication and so forth. I don't think I ever got a follow-up call from either of the doctors that I worked with. And so I just find this interesting.
Yeah, absolutely. And I don't want to be a hypocrite either. In the emergency department, I can tell you I did a poor job of that, following up with patients. And we were blessed at some of the ERs that I practiced that we had nurse managers follow up with patients who had acute trauma or things that required opioids and would try and steer them in that direction. And that's a really great initiative that hospitals are making. And that's kind of been an ad hoc thing, but it needs to become more streamlined and more regulated.
Absolutely. So obviously the bandwidth of this problem is enormous. So what is the current plan to address the crisis in the United States?
We're still fact gathering, so in many ways we're being asked to build the ship as we sail it. But the 3 biggest prongs that have come out, we talked about improving opioid prescription, and that really falls on healthcare providers in the medical system. And the quick and dirty of that is, we're trying to make sure that opioids are used judiciously, that they're not first-line therapies, that there's communication with the patient about realistic goals, and that there's realistic interaction that involves reassessment and getting them off them as fast as they can. Also informing the patients, just making sure like, hey, this is a highly addictive drug and it can go south in a hurry. And this is why we're going to schedule your pain management with some non-narcotics and try and get you off the opioid part of it as fast as possible. And that is not a perfect solution to your pain, but it is a safe solution. And that's going to be important. We also at a higher level, preventing opioid disorder to begin with. So that's education of the public like we're doing today, and trying to give people access to information so they understand the problem and the scope of the problem and can be proactive with their healthcare providers. That's education to healthcare providers and practitioners who don't traditionally write for opioids and maybe are less versed in understanding the doses they should select, the specific pill they should select. And frankly, some physicians were irritated by it, but I think pharmaceuticals did a good thing by removing certain choices off the market because they were inherently dangerous. And then also creating treatment of opioid disorder. When someone realizes they've got a situation with opioids, it's not just a quit by willpower deal. As we talked about, they're chemically addicted. So providing medication-assisted treatment, or MAT, is really the most effective way, along with psychological support, because this deals with a whole host of emotions. An addiction disorder isn't just a simple chemical thing. It's also changes their personality and outlook on life, and trying to support them in that regard. And so we're trying to tackle it in many different ways.
So that makes a lot of sense, especially your last point. I mean, it's a problem. You need a holistic solution because it impacts so many different areas of the brain and what that looks like.
Absolutely. I completely agree.
So it sounds like there are steps that are taking place to maybe reduce the issue and the crisis and so forth. But From your perspective, and how are we doing? Where are we today? Because we spent the majority of the show educating, talking about how bad this issue is. Are we making progress?
I don't think we're making progress the rate that we want to. We're not where we want to be at this time, but we do see some positive things. In 2017, the number of overdose deaths involving opioids, particularly prescription, as well as illegal, was 6 times higher than it was in 1999, and that saddened us deeply. But what I can tell you is the number of opioid prescriptions has declined pretty significantly from 2012 to 2017. And it's fallen to a rate of prescription the lowest it's been in more than 10 years. And so we do see healthcare providers responding to the education they're getting. We do see more judicious use of pain meds. We do see better partnerships between patient and healthcare provider and a greater understanding. What we've got is also that issue of the increase in heroin and addictive non-synthetic opioids such as fentanyl infused. And we've got people that have acquired this addiction over the last 10, 15 years that we're trying to get off of it. And so I think we are limiting new potential patients. We're trying to make sure we don't draw anyone else into this crisis. But healing the folks that are already addicted, that's something that we're actively trying to work on and improve.
And with the folks that are already addicted, obviously, rehab comes up quite a bit. Do you have any stats on, rehabilitation and whether that's successful or not? I mean, I know people will talk about, they went from one facility to another, or they relapsed, or it's incredibly expensive and it's, there's only a limited amount of people that can join those facilities. Do you have any thoughts on that?
Yeah, all those things you said are true. It is expensive and it varies state to state, and it varies whether you have insurance or you don't. And so there's a lot of variables in play there. What I can tell you is it goes back to the holistic approach. If an individual can receive medication-assisted therapy to provide them with a drug that mimics opioid but is less addictive, there's less of a high or a rush, and it slowly brings them down, along with as much emotional support as they can get. Now, if that's a licensed therapist, there's an advantage to that. But family and friends can offer some input as well. The big thing is if you're trying to get someone to sail their way through an addiction and come out the other side okay, you can't expect them to do it by themselves. It requires a great deal of support, both from healthcare providers and folks that are adept at dealing addiction disorders.
So, Chris, if someone listening knows someone or has a loved one or a friend that's dealing with this now, I mean, what are some of the first steps that they can take to help that individual?
I'm going to assume that someone is probably not in healthcare to begin with. So I think the first thing that I would realistically do is sit down with that individual and have a difficult talk. And it can't be persecutory. It can't be something that's aggressive. It can just be, I'm worried about you. I've noticed the following things and I'm concerned about this. Do you think I'm right? I would ask questions. Often folks deny. They don't want to admit this. It's very embarrassing.
Yeah,
it's a setback in their job and their social life. But the key element is offer help with no judgment. And then once you've done that, you kind of, as the person helping out, need to put in the legwork and the effort to get them to a healthcare provider that can counsel them.
You bet.
And, there are many ways you can do that depending on your state. You can reference clinics, organizations, hotlines for opioid addiction. And honestly, if you have nowhere else to turn, I would honestly think about taking them to the ER. And it's a reasonable place if you can't figure something else to cue them through a social work process to get them where they need to be.
Yeah, I know that, we work with a lot of different families across the country. And this is, as you mentioned earlier, it's an epidemic. It hits families with no boundaries, if you will. And we've had conversations with clients about this very issue. And even as advisors, we've been able to help guide people down the right path, putting them in touch with the right professionals. So it's, I guess because the issue is so big, there's so much that's out there, at least for help. So I appreciate those thoughts.
Absolutely. Well, I appreciate you having the opportunity to chat with you today.
Chris, thanks again for joining us on the show today. I mean, topics like these are very difficult to talk about, especially if it's a friend or another loved one. Just emotionally becomes very difficult to talk to somebody who's dealing with an addiction. But the better educated I think we are, the better prepared we can all be. So, Chris, before we let you go, I'm going to ask you the same question we ask all of our guests, and that is, what is the worst financial decision you've ever made?
Well, you're going to actually love my answer, seeing as how you spend a lot of your time at Mariner. But educated as a physician and thinking falsely that I was a smart guy, I thought I could manage my finances on my own. And it took me until my mid to late 30s to turn to a financial advisor. And they looked at the mess that I'd created and they're like, oh man, we need to help you. So I can honestly say with no prejudice whatsoever that I probably should have interjected a financial advisor earlier in my life.
Well said. Well said. And we'll leave it at that. But Chris, thanks again for your expertise, your passion, and your time today. Thank you.
Thank you. It was a pleasure.
So everyone, thanks for listening to the show today. If you have questions, ideas, comments for the show, please go ahead and email them in at podcast@marinerwealthadvisors.com. Thanks again for listening.
Mariner LLC, doing business as Mariner Wealth Advisors, or MWA, is an SEC registered investment advisor. Registration of an investment advisor does not imply a certain level of skill or training. MWA is in compliance with the current notice filing requirements imposed upon registered investment advisors by those states in which MWA maintains clients. MWA may only transact business in those states in which a notice has been filed or qualifies for an exemption or exclusion from notice filing requirements. Any subsequent direct communication by MWA with a prospective client shall be conducted by a representative that is either registered or qualifies for an exemption or exclusion from registration in the state where the prospective client resides. For additional information about MWA, including fees and services, please contact MWA or refer to the Investment Advisor Public Disclosure website at www.advisorinfo.sec.gov. Please read the disclosure statement carefully before you invest or send money.